So we've got an examination video here, which we'll run through. It goes once again about 5 minutes or so. And this is Jill putting Pat through his paces. So we'll let this video run for a few minutes, and we'll come back and we'll talk about what you've just watched.
Pat, what I want to do is just have a look at your calf bulk and the muscles in your leg to see if you've got some wasting in it. And I can see, in fact, that there's a little less bulk on this left side in this part of your gastroc. And I would argue that there's a little less bulk in this soleus as well. So that suggests to me that your rehab probably could be improved so that we can get everything back. This is your hamstring side. On the right, so your hamstrings look pretty good, but I would argue maybe even there's a little less bulk right through that leg, so that might come from plenty of unloading. Pat, can you turn around, and we're going to do some jumping and hopping and things like that. Are you happy to do all that? Yep. If you're not comfortable, just let me know. Okay, so what I want you to do for the start is to go up and down slowly on your toes 5 times, please, and tell me if you have any pain. Any pain?
Minor, 1.
1 out of 10 pain. And whereabouts is your pain?
In that same spot.
In exactly that same spot. Okay. Can you just shift that way a little bit so you can hang on to the bed a little bit? Just, yep, you have to face that way. Yep. Okay, can you stand on your right leg and go up and down 5 times nice and slowly for me? Okay, any pain?
Yeah.
Okay, that's the other injury?
Yeah.
Okay, we'll leave that to be for the moment. Can you do the same on your left for me, please? Okay, what's your pain?
Probably got progressively worse, up to about a 3 out of 10.
3 out of 10, and is it, whereabouts is it?
In that same.
Exact, so it's not distributing anywhere at all. Okay, just step forward a little bit for me. Okay, what I want you to do now is 5 hops on both legs, or 5 jumps on both legs for me, please. Yep, footballers can't count. That's terrific. Any pain?
About 1 or 2 on the left. Yeah.
Okay.
Not too bad.
All right. Now I want you to stand on your right and do 5 hops for me on your right, please. A little bit of problem from that other one.
Yeah.
The other injury. Okay, and let's have a look at the left. Any problems?
Yeah, up to about a 5, 6 out of 10.
Okay, so that's quite substantial. Is it settling as soon as you stop, or does it sort of hang about?
Mildly hangs about. It's just in the background.
Right.
But yeah, settling a little bit.
Okay. All right, so what we would do next is do some big hops. Are you capable of doing that either on your right or your left, or will you feel very uncomfortable doing it on either?
No, I could try on my left and.
Yep, so not comfortable on your right?
Yeah.
Okay, cool. Okay, can you stand on your left leg and do 3 hops for height without stopping for me, please? Okay, what's your pain?
It's actually similar to
the natural hops,
yeah.
So it doesn't make it any worse?
No.
Okay, and is it in the same spot?
Yeah.
Okay, so it's not distributing again. Okay, fantastic. What we'll do now is have a look. Are we able to look at your calf on your right side, or are we complicated by your other injury?
In terms
of number of lifts you can do?
I can try.
We'll see how we go.
Yeah.
All right, can I get you to take your shoes and socks off for me, please? Can I get you to face the bed and hold on just with your fingertips? So what I want you to do now is stand on your right, and I want you to keep your knees straight. I want you to go 1 second up, 1 second down, and I want you to do as many as you can without hurting yourself. Until you feel a little bit of fatigue in your calf. So not going further than a little bit of fatigue. Off you go. What are you feeling?
Kind of a bit of discomfort in the Achilles, but it's not getting too much worse.
Tell me when you got calf fatigue.
Fatigue, yeah.
Right, so that's 13. Can we have a look at this right one? So remembering keeping your knee straight. Seeing a little bit of effort here now. Go to the same amount of fatigue. So that's 12. Okay, did they feel similar in terms of your capacity on both sides?
Yeah, the calves did.
Yeah, so you didn't feel, what, did you have Achilles pain?
Yeah, and it's still probably lingering a bit from the...
From the hopping? Yep. Okay, cool, excellent. So you're able to do 12 and 13 with a little bit of fatigue. That's certainly not enough. So one of our rehab things would be to improve that, as well as improve the compliance of the tendon so that you can actually do some jumping and hopping. So we'll discuss that. Okay.
Yep. So I wrote down a couple of things there, Jill. There's just a couple of little things. I just wondered, like he could only punch out 12 reps each leg. Like, for someone that's playing elite level football, like where do you think that standard is for him? Is it no surprise to you that he may be struggling with his Achilles tendon?
I was actually surprised he could do as many as he could, and he's clearly had very good instruction because he was doing them well. He wasn't cheating in all of the ways that we've talked about.
Yep.
But 12 or 13 is still, as you say, completely insufficient.
Yeah.
I know, again, going back to what the dancers do, so this is Sue Mays's work, that 25 is pretty much a minimum. 35 is what they really aim for, 30 to 35. But we're talking about very high level athletes who use their calves a lot. So I think you can probably, anything less than 20 is unacceptable.
Yeah.
25 is ideal, 30 would be absolutely wonderful.
Yeah.
It's really hard to do 30 slow quality heel raises as a test.
Yeah. And do you think his pain there was kind of affecting that, or do you think because there was your cues were go to fatigue, but he wasn't, his pain levels are okay. Like, I don't know, I wasn't there on the day. Do you think that he was able to achieve a bit more? Do you think he was done and pain wasn't so much of an issue here?
Pain wasn't so much of an issue because from a tendon perspective, it's slow loading, so it's not going to create pain.
Yep.
And if that was creating pain, I would be interested in why. So sometimes you see pain right at the top of range and you start to think about posterior ankle joint, or pain right down at the bottom. So you might be starting to think about more of your medial tendons. So I wouldn't be expecting pain was the problem. And again, we were just careful not to push him too hard because he was in a sort of a rehab phase and don't want to take him into so much. You might give them delayed muscle soreness for 3 or 4 days if you take them beyond that capacity. So we tend to stop there and try and match it side to side. So, but I don't think pain in his Achilles was an issue.
Yeah.
All right, so let's look at reviewing now. We've had our subjective and we've examined some things, our alternative diagnoses or contributing pain sources. So in a patella tendon, it will be tendon or patellofemoral joint or something else. Many of our other tendons can be a little bit of tendon and something else as well. So you can have a hamstring tendinopathy and a little bit of neural irritation. Or you can have just the neural irritation, or you can have just the hamstring tendinopathy. So you have to be looking for all of these options. So our neural sort of sources are not uncommon in our sural and sciatic nerve, but they're usually low grade. We're not talking, as I said, profound neural change, a little bit of perineural irritation, or perineural sticking, sort of almost like where your nerve's not gliding quite as much. And they often respond relatively well and quickly to some neural mobilizations. So we have some non-enthesial bursters. So our enthesial bursters are the ones that are between the tendon and the bone. So our retrocalcaneal bursa, our trochanteric bursa, our hamstring bursa. But the two that give us problems are our superficial bursa at the heel, which sits above the Achilles and beneath the skin. So that's direct pressure from a shoe usually that creates the problem. And the prepatellar bursa at the knee. And that's often a fall or more commonly an infection. So they get a graze on their knee and they can get an infection in the prepatellar bursa. I just had an email from someone. There's a friction syndrome in the prepatellar bursa you see in cyclists. So they come in and they report anterior knee pain. It's not getting better and it's diagnosed as tendon. And you can actually get almost a sticking of your prepatellar bursa. So that's prepatellar friction syndrome. So that's interesting. And then our joints, patellofemoral joint, posterior ankle, hip joint. Remembering our glute med ladies have back issues and hip issues and hip OA and all of the things that contribute to pain in and around the hips. So we have to be exactly that very first slide, we have to be holistic in how we assess these people and not putting anything absolute in our diagnosis. And remembering that our ankle dorsiflexion and first range is critical as an important shock absorber. So we've sort of talked about that.
Yes.